In this lecture of lung cancer, referred from Harrison's Textbook of Medicine, we are going to discuss the etiology, classification, pathology, clinical manifestations, diagnosis, staging, and treatment of various kinds of lung cancer. Let's get into it.
This sequence starts with something called etiology. Etiology is simply a medical term for the root cause. It describes the specific genetic and environmental origins of a disease. It is the exact spark that initiates the disease process within a perfectly healthy human body. Let's look at the mathematics of the tobacco epidemic. The numbers are precise, and they are alarming. Active smoking carries a tenfold or even greater risk compared to never smokers. The mutation metric is startling. Exactly one genetic mutation is induced for every 15 cigarettes smoked. That is a direct, measurable impact. And switching to light or low-tar cigarettes, that offers absolutely zero risk reduction. Smokers simply inhale deeper and more frequently to get the nicotine. We also have to look at passive exposure, or secondhand smoke. This causes a 20 to 30% risk increase for never smokers who are married to smokers. Then there are alternate devices, like vaping. Vaping has an undefined long-term cancer impact right now. However, these devices are clearly linked to sudden, severe lung damage. This is known as acute lung injury. But environmental triggers extend far beyond tobacco. Let's look at everyday domestic exposures. This includes general air pollution. It also includes indoor household fuel smoke. Prolonged, low-level exposure to radon gas inside homes is another major trigger. Then we have occupational hazards, which are equally dangerous. There are 7 key industrial carcinogens you need to know. These are asbestos, arsenic, nickel dust, bischloromethyl ether, hexavalent chromium, mustard gas, and polycyclic aromatic hydrocarbons. Mining environments are also highly hazardous. They expose workers to radon and diesel exhaust. These environments release high-energy particles. These are called alpha irradiation. They literally physically tear through cellular DNA. Furthermore, high doses of medical radiation are established carcinogens. This includes things like heavy, repeated diagnostic X-rays. Beyond the environment, we must also consider the host. That means the human body itself. Family history is a major factor. It creates a 2 to 3 times excess risk for first-degree relatives. This is often completely unrelated to smoking. Our bodies have genetic codes that usually protect us, but sometimes people inherit mutations in specific areas. This leaves the host highly vulnerable. For example, mutations in the RB gene, which is linked to retinoblastoma, or the P53 gene, linked to Lee-Fraumeni syndrome. There are also specific chromosome variants that increase this vulnerability. These include variants like 5p15, 6p21, and 15q25. On top of that, normal variations in enzyme metabolism can alter how a body processes carcinogens. Because of these genetic blind spots, even never smokers face real risks. The patient's health history also matters. Having chronic bronchitis, emphysema, or tuberculosis increases the risk. Finally, demographics and lifestyle play a role. A low intake of fruits and vegetables in adulthood is a factor. The incidence of this disease peaks around 80 years old. It remains quite rare in people under 40. These genetic and environmental triggers do not act in a vacuum. They force very specific, irreversible cellular changes. This happens deep within the tissues of the lung. To understand these irreversible changes, we rely on pathology. Pathology is the scientific study of disease at a microscopic level. It is the method we use to classify exactly what is happening to these cells. All lung cancers begin in the respiratory epithelium. This is the protective inner lining of your breathing tubes and air sacs. The World Health Organization uses a classification tree to split these cancers into 2 major branches. The first branch is non-small cell lung cancer. This accounts for roughly 80 to 90% of all cases. For this type, subclassification is absolutely critical for choosing the right therapy. The second major branch is small cell lung cancer. This type is highly aggressive. It has a very rapid doubling time. Let's look closer at the non-small cell branch. This divides further into 3 types: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma.
We will examine adenocarcinoma first. This is the single most common subtype in the United States. It is the dominant type found in never smokers, in women, and in younger adults. Under the microscope, it has distinct features. It often looks like tiny glands, or it produces a thick fluid called mucin. It also grows in very specific patterns. Some form little microscopic tubes, which we call acinar. Some form finger-like projections, called papillary. Sometimes it grows flat along the existing lung lining, almost like scales. We call this lipidic growth. A solid pattern, on the other hand, is just a dense mass of cells. The major clinical warning sign here is the micropapillary pattern. This looks like tiny, invasive tufts of cells. It carries a particularly poor prognosis. The size of the tumor is also strictly defined. Adenocarcinoma in situ is pure, scale-like Lepec growth. It must be 3 centimeters or less in total size. Minimally invasive adenocarcinoma is also 3 centimeters or less, but it allows for a tiny fraction of deeper tissue invasion.
Now, squamous cell carcinoma presents very differently. It usually originates centrally in the main breathing tubes. It is highly associated with tobacco use. Its physical shape or morphology is distinct. It presents as continuous, flat sheets of cells. Pathologists look for 2 key identifying features. First, the production of a tough protein called keratin. Second, they look for tiny intercellular bridges. These literally connect the cells together. Conversely, we have large cell carcinoma. This makes up less than 10% of cases. This is strictly a diagnosis of exclusion. That means doctors only know what it is by proving what it is not. It lacks the features of small cell lung cancer, it lacks the glandular shapes of adenocarcinoma, and it lacks the squamous cell characteristics we just discussed.
Let's turn to small cell lung cancer. This has an entirely different clinical profile. It is highly aggressive. It is characterized by a rapid doubling time. It also spreads very early through tiny microscopic seeds. Because of this, it is managed as a systemic disease from the very moment of discovery. The cellular traits are completely distinct. Pathologists look for small cells that contain very little internal fluid. The DNA inside the nucleus looks speckled. We describe this as a salt and pepper pattern. Pathologists will also note a very high rate of cell division. This reflects its incredibly rapid, dangerous growth. But visual identification alone is not enough to catch these details. Pathologists have to use a special laboratory test. This is called immunohistochemistry. This test uses highly specific antibodies. These antibodies act like heat-seeking missiles to identify marker proteins hidden inside the cells. This definitively confirms the exact cancer subtype.
Think of these marker proteins as chemical name tags that the cells wear. To distinguish the non-small cell subtypes, we look for very specific name tags. For instance, if a cell wears both the TTF1 and NAP-A name tags, it strongly confirms primary lung adenocarcinoma. Squamous cell carcinoma does not wear those tags. Instead, it wears the P40 and P63 name tags. Cytokeratin profiles offer another important layer of proof. Non-squamous and small cell cancers wear the CK7 name tag, but not the CK20 tag. Squamous cell wears neither of them.
Further checklists are used to verify other aggressive types. For example, we need to prove if a cancer is the highly aggressive neuroendocrine type. This is the hallmark of small cell lung cancer. To prove this, pathologists need to see 4 distinct name tags. These are CD56, synaptophysin, chromogranin, and neuron-specific analyse. A totally separate checklist is used for a different disease called primary pleural mesothelioma. We need to differentiate this from standard lung cancer. This requires 3 distinct markers. These are CK5/6,
calretinin, and the Wilms tumor gene 1.
This incredibly detailed cellular identification is what allows for precision medicine. Mandatory biomarker assessment is now the standard of care. Target 1 involves screening adenocarcinomas for specific driver mutations. These are flawed genetic instructions. Examples include the EGFR or ALK mutations. These flawed instructions literally force the cancer to grow. Target 2 involves immune checkpoints. Doctors assess a specific protein called PD-L1. By doing this, they determine if a patient can receive immune checkpoint inhibitors. These are breakthrough drugs. They essentially take the brakes off the patient's own immune system. This allows the body to attack the cancer directly.
These microscopic cellular changes do not remain contained. As they multiply, they inevitably and profoundly alter the entire human body. This microscopic multiplication eventually results in macro-level clinical manifestations. These are the visible physical signs. They are the symptoms the patient feels. They are the structural outcomes produced by the tumor growing within the body. Primary tumor growth causes physical symptoms based entirely on its location. Central growth in the main airways is the most common. It causes a chronic cough in up to 75% of patients. It also causes patients to cough up blood. It creates high-pitched wheezing, shortness of breath, and trapped pneumonia. Peripheral growth happens out near the edges of the lungs. This is often completely silent early on. But as it grows, it causes pain against the chest wall. It restricts breathing if the tumor forms a hollow cavity. It can cause lung abscess symptoms. If the cancer spreads along the lung surfaces, it leads to severe oxygen impairment and copious amounts of mucus. Systemically, the body begins to waste away. Patients experience a total loss of appetite, weakness, fever, night sweats, and significant weight loss. We see this in about 30% of patients. This represents a very poor prognostic sign. The tumor eventually causes regional destruction throughout the chest. We see something called Pancoast syndrome. This occurs when a tumor at the very top of the lung invades local nerves. This causes severe shoulder pain that radiates down the arm. Nerve paralysis is also common. Damage to the vocal cord nerves causes hoarseness. Damage to the diaphragm nerves causes extreme breathing difficulty. Damage to the sympathetic nerves causes Horner syndrome. You can recognize this by a drooping eyelid, a constricted pupil, and a lack of facial sweating on just one side of the face. Structural obstructions also occur. This includes blocked windpipes, severe difficulty swallowing from esophageal compression, and blocked blood flow to the heart. Finally, direct cardiac extension can happen. This causes fluid buildup, pressure on the heart, irregular beats, and eventually heart failure. The final stage of this structural failure is metastasis. This is the aggressive, lethal spread of cancer cells. These cells travel from the primary lung site to invade distant, healthy organs throughout the body. This metastatic spread is overwhelming. It is found at autopsy in over 95% of small cell lung cancer patients. It is found in 80% of adenocarcinoma patients. When it invades the brain, it causes headaches, seizures, nausea, and localized nerve failures. When it invades the bone, it results in extreme pain, spontaneous fractures, and life-threatening spinal cord compression. Liver and adrenal invasion cause an enlarged liver, severe abdominal pain, and fever. Finally, invasion of the bone marrow is absolutely devastating. It physically pushes out healthy cells. This results in dangerously low blood cell counts. It also causes the release of immature, defective cells into the bloodstream. The final clinical manifestation involves something called paraneoplastic syndromes. These occur when the immune system accidentally attacks the body, or they happen when the tumor itself secretes abnormal hormones. Endocrine syndromes include dangerous spikes in blood calcium. This happens mostly in squamous cell carcinoma. Small cell lung cancer often triggers abnormally low blood sodium levels. It also causes hormone imbalances that mimic Cushing's syndrome. Skeletal issues can also arise. This includes swollen, club-like fingers in about 30% of cases. Neurologic syndromes include a rare autoimmune condition. The body's proximal muscles become deeply weak, but strangely improve with effort. This is strongly linked to small cell lung cancer. Finally, blood and skin syndromes include abnormal blood clotting and severe muscle inflammation. Effective lung cancer management requires a meticulous approach. It is a true step-by-step process, from your initial suspicion all the way through diagnosis, staging, and treatment. This pathway is a continuous sequence. Every single clinical fact directly informs the next step you take. At the very core of this pathway is a comprehensive, multidisciplinary approach. You cannot do this alone. Every decision requires input from multiple medical specialties. This creates a continuous loop of care, and that care is centered directly on the patient's lungs. We begin this continuous pathway with diagnosis. This is the foundational step. We must establish the precise tissue type right away. Why? Because that exact tissue type drives all of your subsequent clinical decisions. As the saying goes, tissue is the issue. We need different biopsy techniques for different tumor locations. For adenocarcinomas, lesions are often peripheral, so you will use a transthoracic image-guided percutaneous biopsy. Central squamous or small cell diseases are different. They require fiber optic bronchoscopy. This includes bronchial or transbronchial approaches. If you need targeted sampling of lymph nodes, you perform endobronchial ultrasound. We call this EBUS. There are strict, mandatory rules for these biopsies. First, you must prioritize core biopsies over fine needle aspiration. You need to preserve enough tissue for mandatory molecular and PD-L1 testing. Second, if you suspect metastatic disease, you must biopsy the most distant site first. Finally, beware of the limitations of sputum cytology. It is nearly 100% specific. However, its sensitivity is less than 70%. It simply does not provide enough tissue for modern genetic profiling. Once you have the tissue, you must subclassify it. If it is non-small cell lung cancer, you must define it as either squamous or non-squamous adenocarcinoma. Simply diagnosing non-small cell lung cancer not otherwise specified is no longer accepted in modern practice. Precision is absolutely required here. This precise subtype directly dictates your chemotherapy and targeted agent selection. Next, we use specific imaging modalities. PET-CT is superior for evaluating mediastinal nodes and extrathoracic metastases. On that PET scan, look at the standardized uptake value, or SUV. An SUV greater than 2.5 is highly suspicious, but remember, tissue confirmation is still required. You also absolutely need a brain MRI to check for metastases. It will be positive in 10% of entirely asymptomatic patients. It is also vital for evaluating superior sulcus or brachial plexus involvement. Moving seamlessly forward from diagnosis and imaging, we advance to staging and physiologic reserve. We need to define the exact anatomic extent of the disease. We also need to know the patient's physiological readiness for treatment. Both are critical for planning your next steps. For non-small cell lung cancer, we use the 8th edition TNM anatomic staging system. TNM stands for tumor, node, and metastasis. T evaluates the primary tumor size and its invasion into surrounding structures. N evaluates regional lymph node involvement. And M evaluates the presence of distant metastasis. Let us break down those exact TNM criteria. A T1 tumor is less than or equal to 3 centimeters. A T4 tumor is greater than 7 centimeters, or it invades vital structures like the heart, trachea, or esophagus. For nodes, N1 means ipsilateral hilar or peribronchial nodes. N2 means ipsilateral mediastinal or subcarinal nodes. N3 indicates contralateral or supraclavicular nodes. For metastases, M1A includes malignant pleural effusion or contralateral lung nodules. M1B is a single distant metastasis. M1C means multiple metastases. Notably, there are absolute contraindications to curative resection. You cannot operate curatively if the patient has extrathoracic metastases, superior vena cava syndrome, vocal cord paralysis, or a malignant pleural effusion.
Small cell lung cancer staging is much simpler. It is divided into just two groups. Limited stage means the disease fits entirely within a single radiation port. Extensive stage signifies spread beyond the mediastinum or hemothorax. This extensive stage accounts for 60 to 70% of all patients at presentation.
Alongside staging, we must determine physiological reserve. A patient must have adequate lung function to tolerate surgery safely. Look at their FEV1, or forced expiratory volume, in 1 second. They need an FEV1 greater than 2.0 liters to survive a pneumonectomy. They need greater than 1.5 liters for a lobectomy. You must also check for strict surgical contraindications. These include a myocardial infarction within the last 3 months, uncontrolled arrhythmias, severe pulmonary hypertension, or a DLCO below 40%. DLCO is the diffusing capacity of the lungs for carbon monoxide.
With the staging and physiological reserve clearly established, the protocol now guides our specific treatment choices. Let us begin with localized and locally advanced non-small cell lung cancer. This applies to clinical stage 1 and 2 non-small cell lung cancer. If patients are medically operable, they undergo surgery. A lobectomy is preferred over a wedge resection. It offers lower recurrence rates and better overall survival. After surgery, we use cisplatin-based adjuvant chemotherapy. This improves 5-year overall survival by about 5.4%. However, do not use this for stage 1A disease. It is actually detrimental in those cases. For targeted adjuvant therapy, if you find an EGFR mutation, you prescribe 3 years of osimertinib. What if the patient is medically inoperable? Then you use stereotactic body radiation therapy, or SBRT, for small nodules. This uses high radiation doses in very few fractions, achieving greater than 90% local control. For stage 3, locally advanced disease, management shifts significantly. For non-bulky N2 disease, we start with surgical resection, followed by adjuvant chemotherapy. But if the disease is bulky or unresectable, you must use concurrent chemoradiotherapy. Delivering them together is superior for survival, even though it increases toxicities like esophagitis. This is followed by exactly 1 year of maintenance durvalumab. That is the standard of care consolidation immunotherapy. Finally, for superior sulcus or Pancoast tumors, the protocol is neoadjuvant chemoradiotherapy followed by surgical resection. However, surgery is only an option if there is absolutely no N2 lymph node involvement. If the patient's disease falls outside the bounds of localized treatment, our strategy changes completely. We transition our focus to stage 4 systemic strategies and small cell specific protocols.
For stage 4 non-small cell lung cancer, identifying the underlying biology is critical. Broad panel next-generation sequencing is absolutely mandatory for advanced adenocarcinoma. You are looking for specific oncogenic driver mutations hidden within the tumor's DNA. Specific driver mutations dictate exact targeted agents. It is a highly precise matching process. For EGFR mutations, you use osimertinib, erlotinib, or gefitinib. For ALK, you use alectinib, brigatinib, or crizotinib. ROS1 requires crizotinib, entrectinib, or lorlatinib. If you find a BRAF V600E mutation, the combination of dabrafenib plus trametinib is required. MET exon 14 skipping uses capmatinib or tepotinib. RET mutations dictate selpercatinib. And finally, NTRK fusions are treated with larotrectinib or entrectinib. But what if your stage 4 patient does not have any of these targetable drivers? Then you test for PD-L1. A high PD-L1 score of 50% or more allows for immunotherapy on its own. We use pembrolizumab or atezolizumab. This monotherapy is often superior to traditional chemotherapy. Conversely, if the score is low or negative, meaning below 50%, you must use combination therapy. The standard here is chemotherapy plus immunotherapy. For your cytotoxic chemotherapy options, platinum-based doublets remain the core. You utilize pemetrexed for non-squamous histology and gemcitabine for squamous cell carcinoma. Now let us cover the management of small cell lung cancer. Limited stage disease relies on concurrent chemoradiotherapy using cisplatin and etoposide. The protocol is very strict here. Thoracic radiation must begin with the first or second cycle of chemotherapy. Extensive stage disease is treated with platinum chemotherapy, etoposide, and immunotherapy, such as atezolizumab or durvalumab. For specialized interventions, consider prophylactic cranial irradiation for all limited stage patients or extensive stage patients with a good systemic response. It improves overall survival in limited stage disease. For relapse or second-line treatment, topotecan is the standard. Alternatively, you can use lurbinectedin, which shows a 35% response rate in chemosensitive disease. Regardless of the staging or the specific systemic therapies you choose, care is never just about shrinking the tumor. We must continuously integrate supportive and palliative care into the pathway. Early integration of palliative care alongside standard oncology care is vital. It directly improves both quality of life and overall survival in metastatic non-small cell lung cancer. We must also be fully prepared for acute emergencies. A suspected malignant spinal cord compression is an absolute emergency. It demands urgent high-dose dexamethasone, followed immediately by radiation therapy or surgery. Superior vena cava syndrome is treated with radiation for non-small cell or chemotherapy for small cell, plus endovascular stenting for rapid symptom relief. Massive hemoptysis is a life-threatening emergency. It requires immediate airway stabilization and bronchial artery embolization. This multidisciplinary paradigm forms a continuous loop of care. The surgeon, radiologist, medical oncologist, and palliative care physician all work together in real time. First, we diagnose and subclassify, because tissue is mandatory. Second, we stage anatomically and physiologically using TNM criteria and pulmonary reserve tests. Third, we determine the personalized intent. Curative intent applies to stages 1 through 3 non-small cell and limited stage small cell. Palliative or personalized intent applies to stage 4 non-small cell and extensive stage small cell. This is always driven by molecular testing and rapid complication management.